The first tap of a conductor's wand. The first rivet in a mile-high tower. The master link at the genesis of the never-ending chain. The moment a single empty canvas meets a singular master stroke. There is no one thing. Because now, there are many. Because soon, there will be more. Because one is ever the beginning. Like the first link in an infinite chain, or the first rivet in the tallest skyscraper. The master stroke is found in the masterpiece. What will you begin?
Hello, good morning, good evening, wherever you are. Welcome to the 35th episode of the World Blockchain Roundtable. Our hosts for today are Greg from Ribbit.
Hey guys.
Dr. Everardo Barojas, founder and director of Prescrypto, pioneering a blockchain-based open-source e-prescription platform for LATAM, dedicated to product design and development since 2012, an academic background as mechatronics engineer, a master's in astronomical instrumentation, and a PhD in finance and management. Welcome to the show, Ed. We have Jay Rosen with us. He's a metaverse architect from Mirror Vision Labs. If any of you have gone and checked out the Den Social estate in Decentraland, if you've poked around to find that, he's the guy that built it for us, and some of his artwork is up on the wall if you want to go check it out in that estate. Ross is with us from Global Crypto Press. Always excellent to have Ross on board with us as well, so thank you for being here. And I'm Dave, and I'm from Den Social. Joe's out today, so I'm going to be doing this, hosting a little bit and pitching in where I can. So a couple of updates. Last week, we did not go out for rebroadcasts on Twitter. There was a streaming issue from the platform that we're on. And so we did get a lot of views on the other platforms, but not nearly as many as we would have had it gone out as scheduled on all of them. So for this week, each host from last week, we will receive 333 lot. These are the ownership tokens for this show that come with participation. And the topic contributors from last week, anybody who was voted up high enough for you to be able to get on the show and have the topic discussed, will receive 83 lot. These ownership tokens come with perpetual passive income, free edits in the layer here in the WBRT layer, almost forgot the acronyms, and governance votes for what we cover next month. So we'll have a round of submissions. We'll take the top 13 or however many, and these tokens are what you use to vote on what topics we get to hit next month. Okay, moving on. We've got themes for February. Exactly what I was just talking about. The GI vote for the themes in February came in with NFT utility, interoperability, mining, and a deep dive into layer ones. So those are in order, I think, are the topics for next month in February. Man, I'm happy to see mining on there. Maybe we can get Jay back on for mining too, because I know he and I talk about that quite a bit offline. Let's see here. The theme of this week is health and healthcare. And that's, I don't think we've hit anything close to that so far. So this will be a brand new topic for us. That'll be great. Let us roll into that, I guess. How's everybody doing this morning?
Great. Well, it's been an interesting week, right? Like we saw a big change that's kind of health related in the UK that's worth mentioning. You guys all of a sudden who are watching us from there found yourselves in a new world because Boris Johnson announced that they were dropping all of the Plan B restrictions pretty much overnight and pretty much unexpected and with no preamble, just out of the blue.
I saw something about that, but not too much. Yeah.
It probably had something to do with the fact that he was having bring your own beer parties in the middle of the pandemic. That he was simultaneously telling everybody to stay home and not even talk to one another.
Is that why? That was the reasoning for it? Was like completely because of that. Basically, I didn't read up on it at all. So why'd they drop it?
Well, I mean, obviously we don't know their motives, right?
Oh,
but,
okay.
But he was under fire for this at the time it was happening, because people were calling him out. People were not letting go of the fact that he had this government that was putting these directives out there, and he wasn't following his own rules in a way that was pretty blatant.
Yeah, that's not a good look for sure, especially when people are questioning, right or wrong, people are questioning the legitimacy of your, I don't know, we call them executive orders here in the US or whatever they are over there, the rules and regulations that are put, like, people question masks, and people question vaccines, and people question all of this stuff. And my opinion is, whether you're right or wrong, if you want people to listen to you, you've got to take your own damn advice. So I can see that being a problem for people.
Right. I mean, you definitely didn't see Winston Churchill, for instance, telling everybody to fight on and to keep calm and carry on, and then secretly have his exit from Britain prepared so he could duck out.
I think it's an interesting juxtaposition with what was happening with the crown at that point, right? Because these parties that he allegedly made or allegedly attended were right in like one day before, one day after the wake of Prince Philip, right? So I think the crown made a really savvy move with these things. So they're very good at these things. I've noticed.
Is that did it come from the crown? See, I'm totally unfamiliar. I've visited UK, but I don't know a whole lot about like their structure. So was it the crown that said no, drop the restrictions and you're not trustworthy anymore? Is that how that worked?
No.
Oh, okay.
The crown, we don't know what they did, but I would wager that they probably outed the information about the parties.
I see.
In Downing Street.
Yep, absolutely. And they've always been a behind the scenes power since they haven't been a front of house power. That's for sure. So,
and to be clear, this is the Plan B rules, which is the additional rules on top of the, I guess you could call them the baseline rules or the normal COVID rules that were in the UK. Is that right? So not all COVID things are suspended. It's like the extra stuff they put on top of normal restrictions, or whatever normal is.
Plan B had to do with their response to Omicron, right? The fact that the first batch of vaccines didn't seem to be stopping it. That was kind of the nature. I think it was the Plan B to the fact that this isn't working like we thought it would.
I saw I think early this week or late, maybe even over the weekend, I saw the UK had very likely crossed a threshold, like basically it had peaked, and cases were coming back down again too. So maybe it was with a little bit of data as well, and it wasn't all political. That could be.
I haven't looked at the data, so I don't want to speculate, especially since we're our wonderful streaming platforms might not like it if we did.
Yeah.
There's certainly some suggestion that the trends noted in Africa when the variant was where the variant was identified and when it was.
Yeah, that was the first data. That was the first sort of like, we don't know, but here's some preliminary stuff. That's been, Omicron has been interesting to watch roll out in a lot of ways, because there was a lot of, what it is to me that's interesting is it's the first time that I've heard people say that they may have been wrong. Like about, because it was, I don't want to say it's not deadly. Of course it is, but it's a little bit more, like it's less deadly than Delta. And at first there was a lot of people jumping on the whole, like, oh, it's a new variant, so it must be worse, right?
This reminds me a lot of
it is worse.
But so many people could not restrain themselves from causing mass fear among the public. Like, it was really weird that these people came out and clearly just spoke out of their ass and just said the most terrifying things they could think of. And now we find out the truth, and seems to be safer than the common cold. Like, make that make sense to me. That means they were that tempted to scare people. What the hell?
Here's what I can say that makes sense to me is that there is in some areas, not all of them, there is a problem with overcrowding in hospitals. I know that I've had issues My dad had a heart attack a month or so ago, and one of the concerns was COVID. He's fine. He's got 3 stents, and he's got better blood flow, and his brain works more. So that's cool. But the concern was like, man, there's all these COVID patients in the hospital, and so he got out of there quick. I can sympathize with that a little bit. I can't sympathize with people who are trying to use fear to, even if they think it's for someone's own good. But I can sympathize with being concerned about overcrowding of hospitals.
Well, and I think this is just a really great touch into the topic that we're on today, because we've all been working with decentralized technologies to take power away from power centers and remove opportunities to have reverse incentives to corrupt systems. And healthcare is a uniquely trust ensconced system, right? Like, we have a special trust relationship with our doctors and with our prescribers and with the people who care for our health. And when you start having, public policy things that intervene with that, and where those things interplay, like being able to see what's happening and trust that what they're saying matches what they're doing, is a big part of this. So, and I'm sure
in the United States is so weird because, what you said is true for the people that you interact with face to face when you're, actually going and receiving any kind of care. But then there's what's behind them, which is the insurance companies and the pharmaceutical companies. Right. So it's almost like, we want to have a doctor that we like, and most people find a doctor that they do like and respect and trust. But behind them is just like this evil cabal, and it's odd.
Well, right. What you just said, Ross, is where my issue is with people who won't talk about that. I don't care as much that what you just said is true. I care more that people dismiss even looking into it, right? So if you think that it's all bullshit, why are some people afraid to even like look at some things? A lot of people that are, conspiracy theorists or dismissed as conspiracy theorists, I think it takes not a whole lot of time for you to do some like cursory research instead of just spamming Twitter or talking on Facebook. Think about how much time people waste that they could be using to not assume something's wrong, but just to go find out. It's
boring though. It's usually due to some boring flaw. Like, ultimately, when people don't want to get into this, because like, who wants to think about certificate of need laws that might actually have restricted hospital bed capacity, things like that. And it's different everywhere because healthcare is a local phenomenon, right? So depending,
that was the point system, right? That awarded people based on like age and race and all that.
Oh no, the certificate of need rules are like, am I allowed to build more hospital beds? First, I have to check with my competitors. The board of competitors has to sign off.
This is getting into like why regulation harms human life sometimes.
I would say that there's a really deep dynamic that we've built into most of what we know of the healthcare sector today, and that is that the healthcare sector and all of the ecosystem makes money when we cure things, not when we prevent things. So there's a really great analogy that Henry Mintzberg makes in his book Managing the Myths of Healthcare, which I recommend anyone who's interested in this to read. It's like we have this precipice with these ridges that's close to town, and people keep falling over, right? And we build all the infrastructure, like the ambulances, the helicopter ambulances, first responders, the people that will treat your injuries and make your broken leg heal fast. But we never actually build like safety things around the precipice. We just are improving our capacity to deal with the people that are hurt. And unfortunately, there's very few people that are able to make money off of preventing the proverbial fall, working within my analogy. Diabetes is a great example of this. As soon as you get sick, the hospital starts making money. The pharmaceutical laboratory starts selling medication to you, and the system is working as it was designed to, right? But how can we prevent? There's very little incentive.
They don't make a dime getting people to cut back on their sugar. Yeah, I got you.
Right, exactly. Right. Yeah. There's really good example that it comes from a third person, so I don't know if it's 100% true, but a guy told me that in Germany, his grandmother was paid something like 300 euros extra if she was healthy, like from her nationalized health system.
Huh.
If you could do that in the US or in Mexico and other places. Mexico now has worse health.
I've heard of
than
that
the
too,
US,
and the
by the way.
doctors get a bonus for having healthy patients as well.
Exactly.
It's like 300 to the patient, 100 for the doctor for each patient he keeps healthy.
It's super like counterintuitive to how it all works here. Like right now, pharmaceutical labs all over are kind of scrambling to figure out how can they make money off of these things, because at this point, like Roche, Pfizer, all of these, Sanofi, all of these massive corporations will make no money if you don't get a disease.
Yeah. Oh, 100%. I mean, I was sort of floored from the beginning of all this that, so I was real excited in the fall of 2019. I'm a follower of biomedical research just as a hobby. Like I'm amused by the discoveries and learning how to read the papers and whatnot. Really not so much the medical, but just the, more the cellular discoveries, the actual dynamics behind that, how the proteins work to make things either work or fail in a cell. And there was this really neat paper published. They described a system to disrupt all single-strand RNA viruses within the cell by creating a mechanism that would interdict and attack a highly conserved trait of pretty much all single-strand RNA viruses. This was available around the time they started developing these vaccines and could have been offered through the same delivery mechanism. It was like, why didn't they go with that one? And it speaks to this thing, right? This problem of what if we were so effective at what we do here that we innovate ourselves out of a job, and healthcare seems uniquely prone to the moral hazard of not wanting to actually achieve that.
It's complicated, and it's also very localized. The dynamics at work are very different in European countries than in the US. And I know nothing about China, but I'm sure it's different there. And also Latin American countries have very different dynamics. So you have a big problem when you're trying to market new things, because the end buyer that will buy these things is very, very different in every country that you sell to. And because of economies of scale, these massive corporations, which have the best research and development facilities that we've ever seen, they can't put their resources to use as efficiently, I think, as in other markets, because of the very specific regulation on market dynamics that exist in different places.
Right, it's a patchwork. It doesn't doesn't make itself super amenable to one size fits all solutions.
I mean, drugs are basically developed budget-wise as what we will make when we can hit the U.S. market, and the rest is just stuff that trickles in afterwards. I mean, you look at the profits a drug company makes. Every country is a small percentage of their profits compared to this huge lump sum that comes from the U.S. because they're billing insurance companies. People don't feel like it's their taxes. People don't understand that they're paying for it in the end.
The U.S. is a shit system.
It's got to be the worst.
I'm sorry
to
say that, but there's one thing where you can notice why the U.S. market is so large. And you can see that with the medication of everyday life, right? And that is that it's legal in the U.S. to advertise directly to patients. This is something unique to the U.S. It's illegal everywhere else because it's an obvious conflict of interest. So you get this, massive companies with massive advertising marketing budgets plugging Ambien in public television and YouTube, which is it really I can't even find the words.
I grew up. I know exactly what you're talking about, Ed, because I grew up seeing those, and that was just normal to me. Like, ask your doctor about this drug we sell on all over TV, that kind of thing. Are you having
really disturbing
symptoms? Ask your doctor about our drug.
Is there were some therapeutics for COVID that were no longer protected by patents. So anyone could produce these. These pills cost like $2 a dose. And I don't know if you've heard of Joe Rogan, a big podcaster here in the U.S., and he took them, and the U.S. media, these news stations where every commercial is from a drug company, went on and said that he was taking horse medicine. The inventor of this thing
That was
won a
interesting,
Nobel
right?
Prize for the use of this on humans. He has a Nobel Prize for it.
Right.
This
And
is
the
ivermectin.
propaganda machine went out, mocked him for taking horse medicine, and every other country that has, universal health care, they're taking this as a COVID therapeutic, and it's working great, and they're not getting this same kind of propaganda.
Right,
It's
and
really
this is the
terrifying
kind of
to
thing
see.
that I was talking about exactly, Ross. That's the kind of thing that pisses me off, because it isn't about whether it's right or wrong. It's about it's a bad idea to even find out for yourself. It's a bad idea for you to even, like, we're going to let you know that you shouldn't even look at that. Not you're an adult human being who can make your own decisions based on watching a comedian who has an open platform for anybody, whether it's bullshit or not, to come in and talk. And it's the same kind
You're
of
willing to let people die, man.
they're
Wow.
like, let's assume for a minute that ivermectin doesn't work for COVID, right? I'm willing to say that to make my point, which is that even in that case, like, the fact that around, like, across the entire media system in the US, the same messaging was played out with literally horse pills, right? The same exact wording, the same exact messaging is put out, is an obvious sign that there's something wrong with the way that our messaging is, when it's not, what do I say? It's not in people's interest. You're creating distrust. You're creating people that don't believe. Now, on the other hand, what if it did work, right? What if it does work and the same thing happens? You're creating people who believe that it doesn't. You know what I mean? Like,
Right. Well, and at the very
same thing-
least, go ahead, Ev.
I was going to say that the same thing happened in the beginning of the pandemic with Elon Musk saying that he was going to take this, I can't remember the name. I think it was quinine and it was a chemical. I think it was a gas or something. But, treating viral diseases is very hard, Ross. So I'm not aware that any public healthcare system is using ivermectin as its sole treatment for COVID. Every viral disease is pretty complicated, and you can see that by looking at the history of AIDS. There's a lot of money to be made with AIDS treatment, and yet it's extremely hard to treat viruses. So if you look at the early, like you mentioned, the common flu, right? Regular influenza there are a bunch of diseases that or complications that you can get from that. They're usually mild. I think about 5% of the cases are severe. And you have some antiviral drugs like oseltamivir, that's Tamiflu. And if you look at the clinical results of how effective Tamiflu is, it takes 1 or 2 days off of the disease. So it's not really effective, right? It's dealing with viruses is hard, and we haven't really figured it out.
Right. Well, it's something. Go ahead.
Go on. Go on.
It's just it is a matter of trying stuff, right? Like, we have these when we run into a situation where we have a healthcare issue that's broad and sweeping, like a pandemic, where we can't deal with it in a way that we know. There's no existing treatment. We try things, and we do trials on, sort of on the spot clinical trials happening at the ground level. This is the sort of thing that I found particularly weird about this pandemic, because we weren't doing, people get diagnosed with it. They get a test, they get a positive, and then they say, okay, go home and come back to the hospital if you start having trouble breathing, your pulse oximeter reading was below 90 or whatever. They weren't sending you home with anything to try. For the most part, as a general policy, we didn't experiment with early treatment, which is unusual considering that has been part of pretty much every pandemic protocol since pandemic protocols were a global thing.
Yeah. I guess maybe that's what I was trying to say poorly a minute ago, which is that I get the impression that people don't want something to work. You know what I mean? Oh no, they want this treatment to work. They don't want that treatment to work. So whoever they are rallies around messaging against it, and they get off on pointing at people saying they're wrong and funny and stuff like that. That's just, that doesn't help.
When you say they, do you mean like pharma companies, the big pharma?
I don't know if there's something organizing it, or if it's just a matter of like how fast information travels on the internet today, whether it's top down or bottom up, the way that this happens. But it seems like there's large demographics of people who just don't want an Eastern medicine to work. They want it to be a Western medicine.
Coordinated signaling, essentially.
Yeah. I think we're just seeing standard marketing in a really inappropriate setting. I mean, this is no different than an iPhone versus Samsung kind of thing, except it's not iPhone versus Samsung. People are fucking dying, you weirdos.
Right. And our system, the only system we know how to roll it out with, starts to feel pretty perverse when human life's at stake.
Yeah.
But otherwise, it just feels like normal every day. And it's when it starts to get used for that it starts to feel like, holy shit, this is oppressive and weird. We have track and trace for toilet paper, and track and trace for your favorite flavor of diet soda, but we do not have a good system for tracking, when you need healthcare. And so we tried to roll one out, and people are like, wait, this is dystopian, man.
Yeah. What would be a good system though is blockchain. So that's what we're going to talk about. Let's talk about how we can fix all that, right? So we talked about problems. Let's talk about how we can apply technology to some of those problems, like the validity of information and whether or not you can trust a piece of data, the source of it, where it came from originally, when it happened, that kind of thing. I think that those sorts of questions are really important, because a lot of this, if you want to call it disinformation or misinformation or confusion, maybe is a very good word, because it doesn't matter who's right and wrong. It matters that we're all confused. Maybe that's something that we can maybe not resolve, but improve, some sort of measurable proof, for example.
If the issues are trust,
blockchain,
then blockchain can help you verify.
I mean, are people lying on clinical trials to get their drug approved really an issue? I mean, I don't know if we can propose a solution using blockchain, but is there a problem?
Well, and it's going to be different. I would say just as far as that question is concerned, it's probably more complex than that. Study design has a lot to do with whether or not a trial comes out a certain way. But go ahead. Ev has a lot to talk on the subject. So
I'm going to be contrarian on this, and I don't think it's a technology problem. I don't think there's any technology stack that could help. Like the problem that was just mentioned about people lying on their clinical trials. It doesn't matter where the information was persisted, right? If there's this happened with the Russian vaccine, where they, there's such a conspiracy theories about where it came from that I'm not going to go into, but it's not it's not approved by the World Health Organization, because they haven't made their clinical trials transparent, right? So if a government doesn't want to make information available to the World Health Organization, there's no technology, trustless, open source or otherwise, that would help or aid in that matter. This is all made so much more complicated by the very weird political situation that we're going through.
Right. Ed, do you think that there's a danger of creating an exclusionary system globally with this kind of thing? If we say, here's the platform we're all going to use, or here's the interoperable systems that we're going to collaborate with globally, then are we excluding people who don't have the desire or the ability to like nations, for example, that don't want to participate in that?
Well,
could it be bad, I guess, the technology?
It's arguably happened, right? This exclusion of the Russian vaccine, the European Union basically accepts the World Health Organization's list of valid vaccines as valid, right? So if you go to Europe, you don't need to have self-quarantine if you have one of these vaccines, right? So if a bunch of people in Mexico were vaccinated with the Russian vaccine, so if you get that vaccine, you can't travel to Europe easily. So that's already.
I see what you're saying. Yeah, right. You have this vaccine, but that it doesn't count on the global stage, kind of deal.
Right.
And it's super effective, right? It's not less effective. It's very similar to the AstraZeneca vaccine.
Right. It's just like claiming that we're not going to recognize natural immunity, even though that's like a basic concept of virology. We're not going to say that's a real thing too.
Yeah, and I'm not saying let's all count on just that, but I am saying that it exists.
Well, I mean, we're talking now about the way that the travel system integrates with your health status, right? Like, it's not that whether or not these things work; it's whether or not a body of bureaucrats is going to recognize that a thing that should be recognized will work. Like it shouldn't. It has a lot more at that point to do with gating entry to your country than it has to do with protecting the health of your country.
And that's really all the use cases for blockchain I can think of. They're all things that I wouldn't support. It'll be these vaccine passports and, basically things that they used to control us more. And I'm waiting for the day blockchain is exploited on us, and it will happen one day. It can't be this fun forever, man.
Well, Ev, maybe before we jump into the questions, which we totally need to do, soon, because I'm sure that our lovely audience is wanting us to get into their topics. But Ev, tell us a little bit about Prescrypto and what you guys are doing, because I think this is you changed a lot of my perspectives on how blockchain can be used in health when you talked about this and the problem you're solving. So,
all right, great. So what we're doing is e-prescription infrastructure for LATAM and specifically Mexico. E-prescription systems that they exist widespread in the US, in the European Union, and the UK, and in Japan. Canada, as I learned, it doesn't really have a widespread e-prescription system, and neither does LATAM, except for one country, that's Costa Rica, somehow. So we came into this industry in 2016, and at that point, I had been working with Bitcoin blockchain and coding on the Bitcoin blockchain since roughly 2014, building hot wallet software for a crypto exchange in Mexico. So I came with this knowledge, looking at this problem and thinking, how could I solve this in the most efficient way? And at this point, right, you have a lot of analogies with the way a prescription works and the way currency works. So you need a way to validate that the prescription is real, right? The pharmacy needs a way to validate that the prescription is real. It needs to validate that it comes from the person that's supposed to be sending it. And those are like textbook applications of asymmetric cryptography. And the most important part is that you have the same double spend problem that the Bitcoin white paper originally proposed to fix. You have it with prescriptions as well. You have to guarantee that that prescription will not be fulfilled in two pharmacies, even if you elaborate a complex attack in which you take kind of two pieces of paper with the same QR code on it and go to two pharmacies at the same time. And this is a problem that every, Visa and MasterCard have it. And of course, this is what proof of work does for the Bitcoin blockchain. And so, I'm looking at this and I'm looking at the solution that others have designed. And in the US, you have SureScripts, and what they did was just a closed, classic client-server architecture where there's like a master server that holds all the prescription data, and it's funneling all of the queries from pharmacies. Looking at this and thinking, this is not the way this should be designed today. So what we did was we built a domain-specific blockchain that would deal with prescriptions in the same way, with the same levels of validation that the Bitcoin blockchain used. And this is what we've been doing. Prescriptions are, because they store structured clinical data, and because the data is not large, right? It's not like an image or a video. It doesn't have any attachments, right? Because it's so simple, we can store the data directly in the blockchain. So essentially, each prescription is an NFT.
Yeah,
and
that's
each
really
NFT,
cool, man. I like that a lot.
Thanks. Each NFT is owned by the doctor. And so ostensibly, pharmaceutical companies will be interested in the information that these NFTs have. And this will give the doctor the opportunity to veto whether or not the big pharma companies can look at his private data. And it will also make him a part of the business if they actually do want to look into their pharma data, which will create all these positive network effects where it will bring and reward early users and bring on new users ahead, which is a business that the doctors have been historically just like pushed out of They've never been a part of this business, and it's a massive business. There's a bunch of companies making a lot of money from data where neither the doctor nor the patient have any consent, or they have no way to opt out of this data marketing. This is a bit different in the US. This is more of a LATAM and third world country problem where there is lax regulation. But what happens here, like the counterpart of what we're doing, is that the patient will get like a shit piece of paper with the prescription, right? He'll get this piece of paper that he has to take to the pharmacy. The pharmacy will take this piece of paper from him. And after that, although the doctor and the patient are out of the life cycle, the pharmacy will actually scan this prescription and sell that data to one of the data collecting companies. And they will scan that data, structure it into a very simple Excel document, statistically extrapolate that data, and then sell it back to pharmaceutical companies, which will use this information to adjust and calibrate their sales efforts towards doctors.
That's fantastic. That reminds me of some of the, like, as a Bitcoiner, you know, that, and we should actually roll into the first question here if it's not changed, because I think that that's a really good answer actually to this first question, even though it wasn't directly to it, because you talk about the double spend problem, which is something fundamental to blockchain as far as solving. But it reminds me also of like the other epidemic, I guess, in the U.S., okay, which is opiate abuse and problems with addiction, and people doing things like cheating the system to get more drugs out of it, and to source the materials, and maybe not knowing which doctors are trustworthy or in it just to make a buck and things. So you could bring transparency to all that. I like especially though the fact that you're enabling. If I heard you right, and correct me if I'm wrong, but it sounds like you're enabling the doctors themselves to monetize their data that comes out of their office. And that's one of my driving goals in what we're doing with DIN Social is like traditionally some company monetizes people as a product and pays them nothing, but we're able to, okay, well, it's your data and it's your information. Let's help you monetize that. But then you get paid for it, that kind of thing. So that's I completely resonate with what you're doing, and I've got not a lot of background in medical, but that sounds like really important work. So thank you.
Pretty huge. You received some seed funding from UNICEF. I mean, that's pretty big recognition right there. How did they find you?
I found them.
Okay. You competed against other startups for that?
It was a sort of an accelerator. Okay. So UNICEF is not particularly known, I would say, in the crypto space. Maybe a bit more if you're really into Ethereum. Yeah, or tech at all. But there's a guy called Chris Fabian who has made a lot of really interesting changes, and kudos to Chris for doing that. But he created this UNICEF fund that he could invest in open source technologies. And he created all of the vehicle, like the bureaucratic vehicle behind that would be, let's say, UNICEF worthy or UNICEF compliant, or even UN compliant, right? So he created a way for this really big company to invest in startups and open source technology. And, they've done an amazing job.
I assume they can help you a lot of ways just besides funding too, right? I mean, they just have a lot of data.
They do. They hold a lot of wisdom too.
Experience,
yeah. They're very serious about what they do. I've never seen. It's almost like working with the military. Like I was part of this accelerator program with them in New York, and they would keep track of all of the team members that went on this trip, and they would check that they would land and they would arrive safely to their hotel. You can, just by working with them, you really learn how to do things properly, I would say.
Well, that's huge. Congrats, though, man. That's I mean, as far as you're legit. That's all I had to see. You're the real thing. Good.
Ross, I love how fast you are, man. Leave it to Global Crypto Press to find things at a moment's notice. That's awesome. So, all right. Now that we're 40 minutes in, it's a good thing that we passed that 90-minute proposal, so we have an hour and a half instead of an hour. That was a great discussion, though. Thanks for that, and especially for laying that out what you're doing, because I haven't looked at any other project doing that quite the way you are yet, or at all maybe. So over to the questions. Let's see what people want to know about in the replies. So if it's your first time watching, these are replies that were submitted in ahead of time, submitted into the World Blockchain Roundtable layer on DIN Social, and then they're voted up, and we will get to however many we can get to from the top down, depending on how the community's voted them up in order. So our first question from Y'all Weird is, what is the primary feature of using blockchain in the healthcare industry? Supply chain, medical records? And this is what I was talking about when I said I think you actually answered a lot of this first question with talking about how double spins are a unique problem that's solved by blockchain, things like that. I also posted as a reply to this a graphic that I got from, let's see, I first saw it from Phil Abraham, who is working on exactly this kind of thing, where interoperability between systems in healthcare. And maybe we can scroll down and pull that up real quick, because I'm
blanking on the specifics, but there was one company using this, and I'm going back like 4 years or so now. They ship certain prescription drugs in these like refrigerated cases that I think actually have like a battery, and they keep the things at whatever temperature they need to be kept at for being shipped like to the other side of the world. And somehow they were using, supply chain, blockchain tracking that would somehow like void out any of these containers that did not reach their destination before like the refrigeration stopped. So then they were spoiled, and they were using blockchain to detect those spoiled ones and calling them back and making sure that people didn't, take these prescriptions that were no longer useful because they, got over the temperature required. So that was cool.
Yeah, that is I don't think I've seen this one before. And obviously they were out to make a point with how they diagrammed this, right? Like this is not meant to clarify it so much as illustrate how complex it is.
That is a lot.
Yeah.
Yeah, I don't think someone made this and said, look how easy it is. See?
Right. Right. This is like a Where's Waldo, like.
Well, each of these systems have to somehow be able to rely on or trust data that it receives from other systems. And everything runs through all of these not interconnected at all, actually, built by different contractors with different languages, with different protocols. If there's an API, usually not, just stuff like that has to be custom built into every system.
It is a densely connected network of networks is what it looks like to me. But they're also probably not interconnected in ways that help them interoperate. It's probably linear.
Well, I think they're interconnected to where it works. It's just not efficient. That's why we have this massive spend on healthcare.
Right. Oh, absolutely.
Completely inefficient.
And I think that's the one point that I would want to make on this question is one of the things that blockchains enable are loosely coordinated or completely uncoordinated creation of subsystems that can then be reconnected once that information is captured, right? So you have the ability to make not one size fits all solutions, but the ability to make solutions that are local that can then later be aggregated into one size fits all reporting. It makes a lot more sense than trying to tailor the system to the reports the people governing would like to receive.
Have you guys heard of Jim Clark?
No, I haven't. Have you?
Dave?
I have not. No, I have not. Jim Clark?
The Netscape co-founder.
Oh, okay. Maybe I should know. I know Netscape was my first web browser growing up, so I know that much.
Yeah, mine too. It was the good one. You had like Explorer and Netscape, and it was like a PC versus Mac battle at that point, right? Which one you sided with? So this is the guy that basically talent hunted Mark Andreessen from Andreessen Horowitz. So he created Netscape, and after he created Netscape, and he made a bunch of money that he spent in yachts and in his next company, which was Healthion. And this was in the year 2000, roughly. So this same excitement that we have to basically fix the healthcare ecosystem with blockchain, we have with the creation and popularization of the computer, and then with the internet. And the effort that Jim Clark made and the amount of money that Jim Clark spent on this, right, was outstanding. And he basically got a team of 3 indie developers that were the best, right? And he created a system that would connect all of that in software, right? That graph, and it was very, very complex. And he tried to sell it. He was related to the first implementation of SureScripts, which is the e-prescription system that works in the US too. Like he made all of this work, and his reasoning was very basic. Was like, healthcare is like 8% of the GDP. So I have to make a business, right? It has to be the next big thing. The learning you get from this is what Healthion became is WebMD. And where I'm trying to go is that none of this matters. You cannot connect. There's no software that's good enough to connect that mess. The legacy systems are way too fucked up.
Right.
If Jim Clark couldn't do it in 2000, when it was simpler, I struggle to believe that any of us can. We just have to build something that's better. It's like there's a bunch of things that the Spanish Empire built on top of pyramids. They couldn't utilize the existing structures because they were too different. I think this is the case. We just have to build over the legacy systems. It's too complex.
Right. And I wasn't trying to suggest that we could connect the graphs, that whole graph with blockchain, by the way. I was actually trying to say say more like it allows for the reporting side of things to be told to piss off when they want to try have an interconnected reporting system. More that you can get the data out yourself from the same system with enough art, and you don't have to attempt to oversimplify the management of the much more complex process of caring for people's health. This was more what I was trying to shoot at.
I think you can, and this is just, I don't know, maybe a personal opinion, but I think it's technically sound. That I think that if you do have a blockchain system that can interconnect with these legacy siloed systems, some of them were built before the internet it was even existed at all. If you can interoperate with these, regardless of like how it was built, then you could connect all of these siloed systems into a blockchain system, and you can build on top of the pyramids that are there, because they can continue to operate the way that they operate. You don't have to rebuild everything. You just need something that can plug into it, that can kind of bolt on to every system and make it and make it communicate with other systems over a blockchain that is verifiable, proven out to something like Bitcoin. So I think that exists, and I think that that's coming. But it is hard, and it's weird to think about blockchain mixing with siloed systems. But it's kind of a thing.
Here's a real world example, Dave. I worked with a hospital that have a legacy system like that. And it was a good system, right? It was not the worst system I've seen. And it was pre-internet, right? So it's an example that it's very similar to what you were saying. The problem that the system has is that it doesn't have structured data. So it's basically a word processor that the doctors would use. And the doctors would input like a note on the patient that would have, this was an oncology hospital. So they input information that was specific to oncology. Like the size of the tumor is that, and it weighs, 500 grams, and it's a regular mass that has a 13 centimeter diameter or whatever. You cannot deal with that data. It's very difficult to interoperate with it. They cannot even, the data.
This is basically a free-form note, right?
Exactly, a word processor. So the data is useful for a doctor that's reading it. But even for research purposes, right, you have like the head of this institution wants to do research on this. He wants to get data and put data science grads to work on this data, and they can't. They cannot figure out a way to make this unstructured data useful. This is just one, like a very slight problem that exists in the real world. This is why I was so adamant before with my point.
That is a good point. Yeah, I hadn't thought of it. I guess I wasn't thinking of it in a way that would allow researchers to more easily apply data to their research, to use the usefulness of the data itself, right? The data itself obviously is still going to be whatever it is. Where I was thinking was more along the lines of efficiency, retrieving data over a series of interconnected nodes, things like that, reliability and cost.
Right, and
if you're retrieving the same thing
Right.
Is there an application to just make it cheaper?
Right, but it's the
Instead of-
standardization of data that will be resisted, I guess, is what Ev's saying.
Yeah, you can't magically standardize data that's already written in the past, right?
Exactly.
And this is an industry that is kind of infamously behind on stuff. And this is something we learned recently with the ransomware attacks is
Yeah.
you have hospitals that are running XP still. Okay. That's because their database program runs on that and it works for them. But then something like this comes up and they have to upgrade now, So I
hang on,
assume the
I
newer
gotta pull up your
programs
file.
do
Just
all
tell
have
me.
an API, which is what you need. Is APIs enabled, then it can interact with anything, But it's not there yet, and they are running some old stuff.
Yeah, to Ev's point, even that API is going to pass data the way that it was formatted originally. It's just going to say, you want the data, here it is. And it's going to give you something that's just, someone's word processor input. And it's not parsable by, or whatever the word is, by, like you can't scan millions of data points and get the same, like get reliable data. You have to manually, tediously read the note, interpret what the doctor had to say, and then make your own data point that is standardized from that.
No, AI could probably do a lot of that now, actually. Interpret exactly what it's looking at.
That's not a bad
thing. They actually can't yet, but they're working on it. Like the natural language processing is advanced, but it's not that advanced to get this data. There's a really good podcast on the A16 feed where Mark Andreessen speaks. I think it's with the director of Roche. I'm not sure if it's Roche or Pfizer, but I'm pretty sure it's Roche. And he, in his words, he states that the biggest problem they have is dealing with the massive amounts of unstructured data. Because, data, I don't like to see it as the oil. I like Benedict Evans' view that it's like sand. So it's sand, right? It's what you're using to build something valuable. And, sand is very important to build anything that's related to AI. And there's a bunch of things that are being developed now to improve, drug development, new drug development using existing data. But what do you do when this existing data is unstructured? There's a massive amount of money being spent on this drug.
Well, I mean, and I don't know, have you guys how many of you guys here have worked with neural networks before and tried to train one?
I haven't.
Okay. It is a uniquely painful experience to try to get it to comprehend just a data set and have it be valid, right? Like just to get to the point where the input is good enough for it not to just arbitrarily break. That's a nightmare. Then you get to the point where there are all these different parameters in the algorithm that you can tune that, often react unpredictably. Like you might change a parameter by adding to it, by increasing some coefficient, just by one unit.
I've had some creepy stuff happen,
and it just flies the other direction. Like it is literally unpredictable in an unpredictable way. So and it gets worse the more data you have. So trying to structure all of that data, if we can get there, if we can build that system that can take and read all this unstructured data and structure it, like that system will be a lot like building a map the size of the territory, right?
My bad AI experiences all seem to be on lack of data, is what I learned it was, at least in my case.
Well, it's lack of sufficiently
data,
diverse data.
Very focused.
Because you can get an AI that looks right all the time on all your test data, right? But you may have just trained it to your test set.
Yeah.
Or you can get an AI that is wrong in just one case, but it's a critical case, and you never know until it's wrong, and you find out that it's wrong because of the blowback. And that's
Jay,
what I think the trouble.
You've got I'll put you on the spot for a minute. You've worked with a lot of GPUs, primarily from mining and stuff like that. But I think you've at least played with AI and machine learning with some of this hardware you've got. Do you have any thoughts on that? On like how far that is going to, maybe how long it's going to take to get there, or kind of how innovative that sort of AI and machine learning really is? How
Well, I mean, with Moore's law, the technology and all these GPUs are just getting smarter. Like every 2 years, it keeps getting faster. So I feel like in the next 10 years, we're about to see computers, they say, get smarter than the human brain. And then, of course, quantum computers are going to be dangerous. But as far as right now, as far as using the machine learning to help us solve this problem, it really is just building side solutions. And instead of just trying to fix the problem, it's building smaller things that could be used to, for example, organize the data, or to, I know, like we recently just used these computers to try and help solve the COVID vaccine. We're using all the computers, I forget that project name, but I know I was part of that for a little while. We were just providing some computational power to groupthink solution to vaccines.
That was sort of like a folding at home, or one of
Folding
the
at home, yeah.
steady at home and that kind of thing.
Yeah, I remember that.
Yeah, like those kind of projects I really enjoy. The idea that it's another way of thinking of how blockchain in healthcare is. People like me and you who aren't really doctors, we actually are kind of part of the solution. Even people who are 3D printing are kind of part of the supply chain when there was a shortage of parts.
That's a cool point there. Basically, like giving everyone easy to use tools that can help people that can do something with that data, or people that can do something with that computational power, even if you don't know how to do it personally. So it turns sort of the plebs into useful resource that you can pay them for.
You know that currently, this just popped in my head, AI is better at looking at X-ray photos and spotting cancer than the human eye.
I've seen that
Way
claim.
more accurate than doctors, yeah.
And that is true. That is accurate, but it also has a probability for error, and we don't know which cases it's going to error on, right? Like there are instances where it is wrong on a clear-cut case for a physician to diagnose by just pushing on it. Like a lot of skin cancers, you can figure out are different kind of worse or better to have prognosis-wise skin cancer by poking on it and seeing how it moves. But you can't tell that from an image.
Yeah.
So if the AI says no, this one's benign, you still got to have that guy who knows that if I push this and it doesn't move, I need to tell this guy he needs a biopsy.
It's amazing something so complex has the simplest shortcomings, man.
Right.
I find it so interesting. Yeah.
Apparently, it works for CAT and MRI also. I haven't verified, but I'm sure that if it works for X-rays, there's more. Yeah. That's interesting, though. I don't think anyone's suggesting that that's like the final word, right? You still have, like it's a tool that a doctor can then use, because that's the scary thing that people I think is
right, it's not people or machines; it's people and machines.
Even before, like doctors are not usually interpreting or making the first interpretation of X-rays, MRIs, CAT scans, or ultrasound. There's usually a technician that's interpreting for the doctor, and he has like a massive room with monitors, and you can zoom in on the original raw file, and then he shares like shareable files and the report with the doctor, and then the doctor is the guy that says how will that be treated. So if you look at what was being done, but the person that this is helping is the technician. He doesn't have to like have good eyesight at that particular point in his life to make the greatest interpretation of the results.
Yep. And it could certainly be used to do something much more banal that I think would be a really amazing check that someone could do with computer vision, and just validate whether or not the image that was taken was of sufficient quality to be diagnostic. Right.
Or double check. Right. Redundancy is the best safety feature there is.
Right. Just another one that we can raise too. I wanted to throw this one out in the air, and I have to briefly step away. I'll be right back, guys. But community governance and medicine. How would DAOs change health?
That's good. That's
I
a
think that's a
question,
really interesting one.
Greg. I could get off onto that for a while, but instead, I think we should pivot over to the next question on the list that's been voted on by the community. So, where are we? Are we at who are we? Angel Breaker? Yes. So Angel Breaker asks for market analysis, and maybe I don't know firsthand the answer to this. Maybe some of you do, but which healthcare companies are currently using blockchain and why? Do you know of somebody who's using this sort of tech, or at least as kind of like dipping their toes into it and seeing how well it works for them? Do you know of anybody specifically? And this is a question for anyone.
I'm not the IOTA project, but IOTA is not really a blockchain. That's a Tangle. But IOTA is using it to track COVID vaccinations and who is sick. There's also a California digital COVID-19 vaccine record in California, and Excelsior Pass in New York State. So some are using blockchain mainly because of COVID. They are really trying to track.
And then we had, that's a good point, because we had in Florida, we had the COVID Safe Pass, which used Dragonchain for that one, which is cool.
There's a lot of medical marijuana coins.
Oh, that is true. There are a lot of those.
Right.
Yeah, I used to mine some of those. I should go look and see if any of them last at all.
That's true, but it's difficult question to answer, right? If you were to try and ask the same question for financial institutions, would you answer JP Morgan because they made that one-time experiment? I mean,
with their own coin kind of thing, yeah.
Exactly. It's weird. I think everyone's experimenting. I don't think there's any major pharma lab that hasn't invested at least $50,000 in some sort of even like simple tracking blockchain projects or something.
So it's very much on the radar.
Yeah, but it's not widespread and it's not relevant. For like in the big scheme of things, none of these projects are really used in a relevant scale on a big pharma company.
Right. Yeah, because they're
Time will tell. It's early, yeah. So we'll see if that ever comes to be.
Well, and they're operating under a highly top-down bureaucratic type of mode of operation, right? To even get into that industry with software, you typically have to have some things that just don't make sense in a decentralized world, right? Like, if your software is community managed by a DAO, who applies for the license to make it so that you can even use it in that context, right? Like, there's no entity involved sometimes. Like these things are going to be some of the complicators, I think.
Right. We need like a bold Michael Saylor type guy from the healthcare space that's brave enough to say I will use it. It's a good idea.
Yeah, absolutely.
Someone to kind of like stand behind it and be somebody that people can point at and say, look, he's doing it and having some success and he says it works. So why don't we all just do that?
And take the heat, take the flak.
Yep.
Yeah. Sure.
The only other thing that I could imagine maybe could get a foothold and then have to be used to be something that could start at the patient level that people could just adopt in the same sort of way that most workplaces started using Slack. All of them were already using it, so the boss says, "Okay, I'll allow it."
Yeah,
it's being used anyway.
Yeah,
on the side. Yeah, I've seen a lot of systems happen that way, where the top down will be like, "Here's our system," and then the bottom up will be like, "Cool, we'll do that." But then to make it to where we can actually work the way we want to, we're also going to use these tools on the side, kind of thing.
Right. Yep.
Let's go to Jacob Wayne's question, which is, do you think that there will be several blockchains that are specific to healthcare, allowing individual hospitals to pick and choose, or do you think that one healthcare blockchain will rule them all?
Mm-hmm.
I think both. Yeah, I think like right now, like Epic is such a popular EMR, and something like that is going to happen again. There's going to be a major software that gets created, probably like a Microsoft or Amazon or Google, which we don't want to happen, but something like that is most likely to happen. But there will always be independent blockchains.
In Longview, I expect there may be several blockchains per hospital that might be unique, coordinating with a chain above that in a different layer that it has to maybe match a protocol to communicate with, but they may adopt their local ad hoc solutions that you just need to be verifiable in the sense that they're tracking a certain kind of data, because a lot of compliance is just making sure that they're tracking to a standard. So how they specifically implement it can vary, and that's a lot of the reason why you have the unstructured data problem, right? Because you can tell the doctor that we have to use this system, but he's going to fill out the field the way he's going to fill it out, and you can't freaking tell him otherwise, right? Because those guys can pretty much tell any governing body to screw off. I'm dealing with this the way I want to. This is part of the Hippocratic Oath. I think that's how we're going to see it evolve. Is like not just multi-chain, but massively multi-chain.
With enough competition, there should be, I would think, and I kind of would want that personally too, to see that. And something as early as this too, I would expect there to be so much potential market to where, at least in the beginning, that no one company is going to be able to like work with everyone at the same time in the whole world. You know what I mean? You might see a whole bunch of companies work with a whole bunch of people, and some of them do it better than others. And then word gets around among professionals and people that operate these systems to like, what problems are you having? Oh, we don't have that on this blockchain. Maybe you should use that one. And over time, that could converge into something that Google purchases or that Amazon purchases, and now they are the whole thing. I don't know.
Hopefully not.
But I don't think it'll happen. I don't think it'll happen monolithically in the beginning. I think that's the antithesis of this entire effort with this technology.
Yeah, it might echo the whatever happens in the crypto space, crypto and blockchain space. It will probably be the same here, right? But I see, like, thinking very futuristically in the future, or into, like, whatever lies ahead. Maybe blockchain, right? What we think of as blockchain today will be uncoupled from the software solutions that will derive from it, and it might not even be called blockchain then, right?
Yeah. Oh yeah.
Whatever crypto is now, it's very divergent, and you have things like Bitcoin, where it's fully decentralized in decision making, code creation, deployment, and consensus, and you have things that are like Binance Chain. I think they might separate at some point, and we might have like very defined segments of different stacks of technology, not necessarily being called a blockchain. And
Yeah.
I see this. It might happen.
It's just called the internet at some point,
I think
right?
you're onto something there, especially too when you think about like where medical technology is headed. Like, are we really going to have the dominion of the small molecule drug last 1,000 years, or are we about to take that to the point where ultimately health is going to be more about diagnosing your current epigenetic state and then customizing some epigenetic changes based on signaling directly to cells? Like, are we going to get to that level of coordination with it to where the model that we currently have is going to stand in the way of that, obviously, but where our technology needs to evolve both on the administration side, so we could keep up with it on the actual health side. Because if we're talking about personalized cellular medicine as opposed to what we do today, you're looking at a different animal altogether.
So here's a cool thought experiment for you guys. If Bitcoin, for the sake of this argument, becomes the next world currency, that will bring political changes everywhere.
Yes.
How would this impact that question, right? If Bitcoin becomes this cross-border currency system, the same might happen to health records everywhere, including prescriptions and the rest of things. So if that happens, right, in a world where like each state and government's currency is not the best option, and you might go for Bitcoin or other crypto instead, where would that leave the problems that we have today, like and Epic's dominance, to Jay point, or all of the other companies' dominance? It's a very weird place to be in that thought experiment. I think it will look very different.
Right. Will there be pirate medicine? Are we going to have cypherpunk doctors essentially running a new system on the side that works better? Right.
For Mexico, will the narco state provide hospitals? Right.
Interesting.
Maybe.
Very interesting. That is I think about that a lot, but never in the way that you laid it out there in the medical field. I think about proving systems and proving that the medicine's not fake. And that's interesting. Because what if you can do all of that without any government at all, period? Without anybody that you have to trust saying, oh no, that's legit. Oh no, that stayed at the proper temperature through transit. You don't need that anymore. What are the political, like that's a maybe that's a question for next week. We're going to go into journalism and talk about some of these more heavily impacting political issues that things like Bitcoin do present, among the way that nation states expect that they would have operated for years. Now, maybe they're getting the message that you have to change everything. I don't know. There's my answer. I don't know.
Right. Well, I mean, and I think there's probably a how we don't want this to turn out too. I think Ross was touching on that earlier. The notion that a lot of the uses of this, actually, maybe that would be an interesting thing to dig into a little bit. Ross, when you were talking about things that you thought would be terrifying for it to be used for,
just tracking, man. Everything Edward Snowden would warn us about.
Yeah, it's a fair point. Because I mean, there's a lot of healthcare that is cultural, and how do we want it to go is a big part of this question. And technology can't answer that for us.
Right. Even like the way we talked about before, or at least I mentioned about Eastern and Western medicine, that's largely a cultural issue to a lot of people, and other reasons too. But let's move on. Let's try to get through a couple of more of these.
All right.
The next question that I have up is from Dragonchain Holder. Asks, how can blockchain impact the privacy, security landscape in healthcare? And there's a side note: get well soon, Joe. Take your vitamins, and we'll see you when you come back around.
Does he have COVID?
Yeah, he got the COVID, man.
Ooh.
He's, like everybody else, it seems like that I know. It's getting less and less. I'm the only one that I know in my friends group.
I haven't gotten it.
One of few that hasn't gotten it. So
I don't think I've gotten it. I don't know. Maybe.
Right. You could have had such a mild case that you sneezed one
Yeah.
morning and didn't think much of it, and that was that.
that's true. It could. Yeah, I wouldn't have known. So yeah, what about privacy security landscape, privacy and security in healthcare, and how blockchain impacts it? Anybody have any initial thoughts on that?
Well, I think the one that stares you in the face that you almost have to address, and I think we should probably set up this this particular canard to knock it down real fast. That the way this is impacting healthcare right now is allowing for hospital systems to be more subject to ransomware attacks. Right. That is I think
today, and here's where we are.
Right, like that is I think where if you ask about the dangers and benefits, the first thing a typical old guard critic is going to point is they're going to go, this decentralized currency stuff makes it a lot easier to crypto lock hospital technologies
Because it exists.
If you have a cryptographic attack and ransomware on a hospital system, you're going to be more likely to pay it. And
another big reason they're such
a
a target, you got to understand the information that they hold is everything you need for identity fraud. So if you can get your hands on a database from a hospital, I mean, that sells on the dark web for a lot of money, man.
Right. But at the same time, we probably all had most of that compromised when what was the one of the big three credit bureaus got all of their data dumped on the dark web. Yeah. We're probably long past the day when people can, can create fake identities because they hacked a hospital.
So,
my opinion.
Yeah, the problem with the ransomware, though, as we said earlier, is just that a lot of these hospitals and systems are using very older technology, like Windows XP, and like even banks too are using like Fortran and COBOL, old mainframe systems. And like we're talking about, like how do they get to use blockchain, or how blockchain help is just update to use Ethereum, use like a Polygon solution or like a Web3 solution. Sounds crazy, but
you make it sound so easy too, like
it just means start developing.
Rebuild your entire system from the ground up to use something unproven, because that's another thing. Read that.
Here's another one.
Planting a seed today for the trees for 20 years from now.
Yeah.
Here's another one. Silk Road type self-medication markets. That's a healthcare application, is it not?
Help me, man.
It could be argued. Like if somebody has a license for a treatment that is legally in a different status depending on where you travel in the world. Even from state to state in the US, the legality of your license changes from state to state. Yep. That could be like law be damned, that could actually help people in certain cases. I could see that argument is what I'm trying to say.
I have a really good application for that.
Okay.
Greg. So in Mexico, vaccines are scarce, right? Mm-hmm. So you have to wait for the government to let you know when you will get the next vaccine. So it's very much the opposite of how it is in the US, right?
Right.
So if like there's a private citizen that wants to get vaccinated before he gets his turn as per the government's schedule, he has to fly into the US or somewhere else. Right? So I could see that work for vaccines in Mexico, right? I don't want to fly to the US. I'm just going to buy a vaccine on the dark web.
Yeah.
If they could, like if the cold chain could be kept, whatever, that would be interesting.
Yeah, it would be interesting to see authenticity and purity and storage requirements and all these things proven on a blockchain system and then offered on some sort of decentralized marketplace that anybody could access. That would be a great application that challenges certain laws that are created because historically we've needed some sort of central trust. If we don't need that anymore, I think it's healthy to ask if we should still do things the same way.
Yep. Well, and I just did a quick search. There's almost certainly everything from vaccines to ivermectin to hydroxychloroquine available through a dark market right
Yeah,
now.
you can buy cigarettes, you can buy anything.
And
That's the one Elon Musk showed, hydroxychloroquine. That's the one Elon Musk was using early on the pandemic.
Was it that, or was it chloroquine? Because they both are the like sort of same molecule.
one of the two.
Yeah.
I can't remember, but they're similar.
Yeah, absolutely. So people are out there buying this right now. It's not, it's not folks lining up at the farm supply store to take animal doses of ivermectin and doing heart guard chewables.
But you could have doctors prescribing these. Like, it doesn't need to be like, because self-medication is not really smart unless you really, really know a lot, right? So
people shouldn't do that.
Yeah, you don't really need to go into the Silk Road use case for self-medication only. Like, doctors could be prescribing this, and in some cases, I'd say they do similar things, right? Where they prescribe something that you cannot buy in a pharmacy.
Right. Well, if you have a prescription and you're legally holding that prescription and you buy it from a place that doesn't require you to submit that prescription, you're still prescribed.
Right. Or with weed, right? Like, marijuana is not legal yet in Mexico. So some people get prescribed weed, and it's like, I can't give you a prescription that will be valid at a pharmacy, and you cannot buy it at a pharmacy, but I will advise you to, smoke weed.
Right.
That's something that I've had. I've literally had doctors at the VA, my doctor, tell me that they can't prescribe me something, but here's a number for a guy. Like, the rules are so mixed up and weird that I've had, in 2 different occasions, I've had a doctor say, I cannot treat you with this because you have cannabis use on your record, right? And even though it's legal in Florida and you have a license, it's still federally illegal. So the VA actually refuses some sorts of treatment to people that have shown, quote unquote, drug abuse behavior. You know what I mean? Because it falls into that category now. And I've also been, this is unrelated to cannabis, but I've had a doctor tell me, we can't prescribe massage therapy, but what you need specifically is a type called trigger point massage therapy. And here's a doctor that I know that works at the Florida School of Massage, and he does a great job. He's $70 an hour. We can't prescribe it to you, but that's the only thing that's going to help you. So there are regulation issues that's like, depending on where you live, can dictate what kind of care you get or what kind of access you get, and things like that.
That's why you need decentralized systems, because that, frankly, that seems just stupid.
Yeah, I know. That's why even though I'm service connected and can get free healthcare from the VA, and every time I hear somebody telling me that we should centralize healthcare into a government system, I'm like, yo, I still pay out of pocket for private healthcare, because no. So there's issues, and blockchain can solve some of them, but not all of them, of course.
That's kind of another interesting use case that I kind of popped in my head in your conversation, is that a lot of the future seeing a doctor will be done as we are talking to each other right now. So say the doctor needs to give someone a prescription, they're not handing over that paper anymore. They're going to want to hand over an NFT, something non-fungible, one of a kind. No one else can copy it,
Yeah.
That's how that'll be done.
Oh, absolutely. Yeah. NFTs are going to be a really big part of everything, but I think this in particular, we've already got prescriptions as NFTs in existence, proven by Ev's existence here on the show. So
I think NFTs are a little ridiculous right now, but there's the use cases anytime there should be one of something. I mean, that's a lot of shit.
Right. Oh, exactly.
There's one of me. For example, I should have an NFT that lets me access your. You know what? Here's something I wanted to say earlier. Sorry if I was interrupting you, Greg. But
go ahead.
The point that was made, and I forget where in the conversation it was, but about personally identifiable information and stealing healthcare data, ransomware, things like that. We build on a system today, and this isn't just healthcare; it's in retail, it's everywhere. But it's accepted to build on a system today that requires a company to collect dangerous information from their customers and hold it in a centrally attackable location that is a magnet for anyone to go and plunder, who maybe is more up to date on the security patches than the company is. You know what I mean? And so, like, just designing the same system in a way that doesn't do that does not centralize and collect plain text information at rest on a server somewhere, is in itself inherently way more safer and secure and more private, even if you do the same thing in a different way. with blockchain technology being able to enable proving something without seeing the actual data or something like that.
Oh, absolutely. I mean, just the mere fact that it makes cryptographic signing something that is a lot more user friendly opens up a lot of security possibilities, I think.
There's a really cool principle that was used by the Bitcoin development team, and that's Kirchhoff's law. So Kirchhoff's law, if you're not familiar, is this law that states that a cryptographic system should be safe, even though everything about it is public.
Yep.
So this is how it should be, right? Everything about these systems should be public, should be auditable, it should be verifiable by anyone. But the data inside should still be safe. As long as we adhere to that principle, we're good.
Right.
Like, there's no the risk of them stealing this data in this massive honeypot. That's just structured, unencrypted data on a server, maybe safeguarded by a simple Postgres password or something. It should be safe.
Right.
As long as we're not doing that.
I mean, and we could be moving towards that much more rapidly, I think, if we didn't have some of the the centralized barriers in place that we do now. And I think that's probably going to be one of the earliest useful applications of blockchain in healthcare that actually helps people.
That's a good question for the first, or a good answer for the first question too, which is, removing barriers as something that blockchain helps.
Yep. It may also enable. I have you guys remember those CRISPR kits that the former NASA scientist put out there? Still selling them.
Not sure.
Site's theodin.com. It's pretty fun.
Yeah. You told me about that. I think a while back.
Really? What were they for?
Right now, I think that he's selling something that you can just. What's the basic target? I mean, he gives instructions on
probably citizen scientist labs, right?
Yeah, citizen scientist labs like glow in the dark mushrooms, or
that
make your own glow in the dark beer.
Yeah, but a friend of mine is. I'm sorry. Go ahead.
Oh, but it's also you get enrolled in a course, and we'll teach you how to use it. And once you know how to use it, you can basically order up any molecule you want, and we can't tell you what to decide.
Wow.
My wife's a scientist. I always think about, I don't have time for it, but I always think about getting some CRISPR kit and having her teach me how to use it, that kind of thing.
Yeah.
Make our dog glow or some shit.
Well, this guy got canceled early on in the pandemic because he biohacked himself with his own homemade COVID vaccine.
Oh, I do remember that guy. Actually, I was reading something. I don't know anything about him though.
He died, or did he die?
Oh no, he didn't die. He's still kicking. He's so dead to the internet that I can't find him.
Yeah,
you have to do an in quotes search for the right thing by accident if you want to find any recent sources that link to his site. But
wow.
So
we've got about 10 minutes left. Do we want to hit on one more question? It's a little bit longer, but we could briefly hit on it as the last one, I think. What do you think about that?
I'm up.
Good.
Hyperion Frequency's got one, and I wanted to get to it since he specifically requested that we do, and we had the ability. So Hyperion Frequency asks, as Web3 is rolled out and people start becoming more integrated with technologies, such as the Neuralink, in tandem with companies like 23andMe, DNA collection companies, how important do you think creating platforms or opening spaces on platforms for people of all walks of life, including doctors, psychologists, philosophers, to examine and have meaningful conversations about their findings, and being able to easily pull related data into spaces for these topics? Such individuals leasing their medical records to particular groups for studies while being paid through the blockchain technology for intellectual properties. I think we talked a little bit about that, and maybe Ev can add some more to this as well. And the last part of it says, think about if your doctor has reports on you that you're paying for. With your doctor's examinations and studies, they give you access to your personal information with their signature. It may be helpful for them to get recognized, or for your results to help save someone else's life. Or maybe having a foreign doctor save you from the malpractice of your own doctor through peer review. Just food for thought.
Wow, there's a lot there. That's a great question.
Yeah, I hate for this to be the one that's like, okay, let's squeeze this one into the last 10 minutes. But
that's someday. It's all someday.
Well, I think
not our lifetime, but
I think one of the key distinctions here is do you own your medical records, right? Do you own your information? You own your biometrics. You own you. obviously, but do you own the records that your doctor's office creates about you? And right now, the answer to that is no in most places, right? Like, you have a right to have that information private, and you have the right to access that information and to know it, but you do not have a right to take the records away from your doctor's office and not give it to them. Like, you can't. Once they create those records, they're their records and your information. So, I think that's going to be one of the bigger barriers we have to overcome before we could make it, make it really patient monetizable data paid to the patient. Because that's not the system we have today. I just wanted to throw that in there. That's my sort of first take on that question.
It's a philosophical question too.
Mm-hmm.
Right?
Yeah.
Do you have anything? I know we talked a little bit before about changing who gets paid for data sometimes, or monetizing it for the individual. Do you have any more thoughts on that with your work?
Well, I think the question was like, how important would it be to create like these institutions? And the answer is very straightforward. It's very important to create these sorts of systems. In that thought experiment that I laid out before, where like if something were to happen that would lead Bitcoin to be the world currency, right? And something similar could happen with health records, then yeah, sure. I mean, you could share your record with someone like a foreign doctor that could be available, digging into Greg's example, maybe through a Silk Road kind of thing, right? Or even if it were illegal in your country to see a foreign doctor, you could maybe hit him up, telemedicine. He could give you a prescription, and you could fulfill that prescription somewhere else. That's in theory possible, and it would in theory provide benefits for both doctors that could access a market larger than their current practice, and patients that could get better healthcare.
Yep. Not to mention taking the cost out of the payer infrastructure, right? Like, all that stuff is what's really makes medicine expensive, is the fact that the back office billing happens to an insurance company, which is beholden to Medicare negotiation rates, and there's this network of payers that is not you, except when you pay your tax bill. So that would be cut out of the cost of something really truly decentralized.
And this is like a sovereign individual type of thing, where
Right.
If your country doesn't provide something like this, then you could access this from the web, because this, what you were saying, Greg, is valid for the US and many parts of North America, perhaps, but like for a guy that lives in Germany or France, where
Right.
they get this, it's not more expensive, it's just free, right? It's included with your 50% tax.
They still have to pay, but they still have to pay to have it administered. It's paid collectively.
Right, but it's already paid, right? It's
right.
Public.
It's prepaid
kind of thing.
Oh, absolutely. And there are merits to multiple models. There are benefits and compromises that you have to make in different systems. Like, I personally use a direct primary care provider, and I like the fact that I'm the customer of my doctor. So so that they have to treat me like a customer as opposed to a statistic.
Right,
but I also have to pay. So.
And I'm not arguing about the relative merits of both systems,
right,
but that
exactly.
if you didn't like your system, you would have an option, and you don't at the moment.
It's very true.
That is true. Yep. I know that's in my household that comes up in conversation some, because I'm a U.S. citizen and my wife's a German citizen. And so we have very extremely different healthcare systems. And so she's lived here about 5-7 years, something like that. So there's still situations where I get the question of like scratching her head, like, why is this so confusing and so convoluted? And so like a lot of our answers here might come from the perspective of someone who grew up in North America without realizing that it's just, it's a blanket statement, but a lot of people in the US seem to sometimes think that this is how it is everywhere.
Right. Well, and I think that's one of the biggest things we have to remember. Like, the problems are different with the different systems. Like, if you're talking South Africa, you're talking both problems of getting people to take care of their health and access to appropriate resources, right? If you're talking different places around the globe, you're talking solving different problems. So it's healthcare is a really big loaded term if you're talking at a global perspective.
It is.
All right. Anybody else have anything on this one? I think we've more or less talked out our time today. I think we hit it right at the hour and a half mark too. So that's pretty good.
Yeah, I would definitely add on that if anybody's really interested in this, this is a forum topic. This is something that can be continued. I know that all of us in here would find interest in communicating intellectually about this topic, and you should continue to research it because ultimately there are lots of problems to solve, and you might be the person who asks the question that inspires somebody to do it. So,
Greg, I always appreciate whenever you try to motivate people to, step up and do something, and I can always agree with that. Yeah. All right, so let's take it out there. I want to thank all of you again. Thanks for coming in to talk about this today. Thank you for taking the questions from the community. We will find out next week after the views are counted up for all of this to see how many lot everyone gets. So everyone watching, share this on social media and stuff. The more views you get that this video gets, the more tokens that the hosts and then the questionnaires, engineers can get. So let's go around. We'll start with you, Greg. Do you have any updates that you would like to put out? Where can people follow you? Let's get some last words from everybody.
Okay, yeah, I started using megatexas.eth because we joked about that on the show, and I got the ENS name. So if you search that on Twitter, you'll find my handle, but my @handle is still Design Heretic. But as far as things that we're working on right now, Rivet is about to launch Cardinal. We're going to have some posts out about that soon. I can't reveal the details of the dates yet, but it is like this close, and we're going to have some big news really soon. So, in the meantime, come check out rivet.cloud if you want to build something that connects to Ethereum, Ethereum Classic, any of the test nets. We can help, and pretty soon we'll be able to help you with a lot more networks than that. So,
outstanding. Ev, you've opened with what you've got going on. Let's close you out with what you've got going on as well, and where people can find more information. I know somebody in chat was asking specifically about what the name of the company or the crypto project that you are building is called.
All right. So the company and the project and the business is called Prescrypto. I personally don't do social media, but the company does, and we're most active on Twitter, and it's @PRE_RX. What we're working on is on integrating more pharmacies. So this is, I don't think it's exciting to the listeners of this, I'm not sure, but it's groundwork that needs to be done for e-prescriptions to be valuable, right? For the patient to be able to fulfill that prescription. That's what we're focusing on since 2021, basically.
Thank you.
By the way, it was great speaking with you guys. This is
likewise.
Absolutely, you're always welcome to come back, man. Open invite. So,
yep, totally. Ross, what's new from Global Crypto Press?
I just published a report. I actually wrote on the downfall of Tether. Finally, for the first time ever, as of yesterday, they are no longer the #1 coin on Ethereum. So they're no longer the #1 stablecoin on the #1 blockchain, which is
so that means
historic.
They're dead, right?
They own that spot since they were created. And I think every other blockchain is soon to follow. They are just on a sharp decline while USDC is just exploding right now. And that's good for everybody because that's actually backed by $1. So yeah, that's up on the front page, globalcryptopress.com or Apple News or Google News apps.
Cool. I'll go look it up myself. Thank you for that. Jay, let's talk about Mirror Vision. What are you working on? What's been happening in your life lately? And how can people find you and follow your work?
Yeah, I've been experimenting with holograms lately, like right behind me.
I was looking at that over your shoulder, man.
Yeah, I was wondering, what is that?
Making holograms, making virtual reality, a lot of little projects, but you can find me on...
What is making that, though? What is that coming out of?
That's a fan. That's a hologram
Oh, okay,
fan.
Yeah, that's dope.
3D LED fan. Yeah, you can find me on social media, Mirror Visionware on Instagram, and Decentraland I'm at 7029 right next to Binance and MakerDAO, Crypto Silicon Valley.
Yep. I remember I almost bought your neighbor's property, but couldn't find that Dan dude. Well, thank you also for coming on, Jay. Appreciate your input. Everyone else, make sure that you that you join the WBRT layer over on DIN. That's where you can put in your questions for next week. We're going to be talking about journalism as related to blockchain in same capacity as we did today about healthcare. I guess I'll give some updates on Den Social real quick. I wanted to go out with a spicy comment. I saw somebody, where is it? Yes, Niels, thank you for your input. I wanted to say that in response to this, our NFTs over on Den actually can end up on any blockchain we want them to. The interoperability is available for anybody who wants to build the way that we've built it. I think it's unique. And there's an update from Den for you that we have NFTs and we can put them anywhere. I don't care if it's Ethereum or Solana or your mom's trunk. They'll get there.
Nice.
But thank you for the input. I wasn't trying to knock on you, Niels. Appreciate that. Yeah, so share this episode. Let's get the views up. Thank everybody once again. Like, comment, and subscribe. And we will see you next week for our journalism discussion on World Blockchain Roundtable. Thanks, everyone.
But why, some say, the moon? Why choose this as our goal? And they may well ask, why climb the highest mountain? Why, 35 years ago, fly the Atlantic? We choose to go to the moon. We choose to go to the moon in this decade and do the other thing. Not because they are easy, but because they are hard. Because that goal will serve to organize and measure the best of our energies and skills. Because that challenge is one that we're willing to accept, one we are unwilling to postpone, and one we intend to win. We choose to go to the moon.